Okay, good afternoon and welcome to the Davies Use Case webinar being presented by TriHealth on TriHealth Surgical Optimization Center. This is the Davies award-winning use case for the value of health IT. My name is Arnold Simmons and I'm the Manager of Quality and Patient Safety Initiatives at HIMSS. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use case have been peer-reviewed to validate sustainable improved patient and business outcome resulting from healthcare and technology-enabled care delivery. It is my pleasure to welcome our speakers for today's call. And Donna, I will turn it over to you.
Great, thank
and
you.
Start when you.
Great, thank you very much. We're proud today to present our Davies case study, but I'd like to give you a little bit of background about TriHealth. My name is Donna Peters. I'm the Director of Information Systems. I'm responsible for the applications portfolio, and I'd like to give you just a brief background. TriHealth is a health system located in the greater Cincinnati area. We have 4 acute care hospitals with about 900 adult staffed beds. We have 1 short-stay surgical hospital, 3 freestanding outpatient surgery centers. We have about 140 outpatient service locations, 150 physician practice locations, 850 employed physicians, about 1,800 physicians on our medical staff, and just over 12,000 team members. TriHealth is really proud of the clinical quality and technical excellence recognition we've received, as well as the recognition for our employee engagement. We're a 2-time recognized Magnet organization, and most recently we're named top 15 health systems in 2018 by Watson Health. We've won Healthcare's Most Wired 7 times, 7 consecutive years in a row, and we've won Ohio's Best Workplace and Best Place for Working Mothers, all recognition that we're really proud of. In 2014, we were awarded our HIMSS Stage 7 recognition, and we recertified that again in December of 2017. Again, something we're really proud of. At this time, I'd like to turn it over to Julie Sheedy to begin our presentation on TriHealth Surgical Optimization Center. Okay, Julie, I'm going to turn it over to you now.
Thank you, Donna. Again, my name is Julie Sheedy. I'm the administrator for our Surgical Optimization Center here for TriHealth. And I'm going to take the next 10 minutes or so just to jumpstart and talk about our journey on developing, implementing, and evaluating our surgical home model. So what is a surgical home model? We define it as a very patient-centered, team-based model of care approach that guides the patient from the decision of the need for surgery through 90 days post-discharge. We also provide a care pathway for the patient with clinical processes and protocols throughout all episodes of care, again, from the time that the need of surgery all the way to 90 days post-discharge. And we continue to work to align with the triple aim of reducing cost and clinical variation. So why do we need to start now? Why are we talking about a peri-op surgical home? Well, we are being impacted on the way our outcomes are currently. We're impacted due to our clinical variation, our lack of coordinated care, and oftentimes our patients are disconnected from our primary care provider. You know, we're doing a lot of great work on various phases of care from pre-surgical services to post-discharge. But really, we need to do a better job at moving that patient throughout the system, what we call a longitudinal care plan. We're looking at this because of the increased cost and the way we are moving towards a value-based model of care. TriHealth about 3 years ago aligned with the American Society of Anesthesiologists and Premier Health Collaborative, and we joined in efforts to really have an opportunity to come together with various health systems, over 80 health systems, to share best practices, evidence-based literature on how we would go about implementing and developing a peri-op surgical home model. It's a national collaborative where we're able to benchmark our work and really use colleagues of experience to guide us through this. So when we started, we began to look at service lines here at TriHealth on where we really had opportunities to improve our patient outcomes. We chose colorectal as preferred service line for a couple different reasons. One, it was a manageable volume. We were looking at Bethesda North and Good Samaritan Hospital, who are part of our TriHealth health system, and there is about 300 patients currently within the colorectal program. We also found that there was a cohesive and collaborating group of physicians and team members that really had that same type of goal and focus. We knew that we needed to move towards a value-based type model of care that was very patient-centered. And we were looking for an engaged service line that really would allow us to be a successful model that we could repeat across the enterprise and bring on additional service lines. So as we picked colorectal, we did look at our data, and we knew then that there are opportunities to improve. We were doing great care, but we needed to do better. Our average length of stay and data that we had pulled from March of 2016 to February of 2017, our average length of stay was 8.2 days. Our surgical site infections were an average of 21, delayed cases of 9, a percent readmission 14%, and our average cost per case to take care of these patients was about $11,700. And our overall patient experience top box was 17.5%. So here is where we were able then to really look at our design and how we would go about implementing and involving clinical informatics to help us move these patients through the system to better care for our patients. We did develop a governance structure of physician leadership, executive nursing leadership, process improvement, clinical informatics, and information technology. We really had to look at ways we could leverage what we currently had here in Epic, which is our solution that we currently use here at TriHealth, and look at our EMR as ways that we can optimize to improve patient outcomes. During our implementation phase, we really developed a lot of training that involved various team members throughout our health system. And we really had to look at a dual process across perioperative services, meaning as we brought on patients into the peri-op surgical home, there were patients that were still being utilized in our standard type of care. So we really had to take a lot of time from that implementation, as well as the challenges that we had in those dual processes of those patients that were part of perioperative surgical home and those that were not, and develop workflows based on that. We also, part of our barrier was to overcome ways that we were lacking discrete documentation and really standardize a process that we could share across the system on our outcomes. Here is an overall our peri-op surgical home core group that was developed. We have at the top there various executive leaderships. We had surgeon champions and also our surgical optimization center champions. Various work groups were created and met regularly at the beginning. We met monthly, sometimes biweekly, and really had to work through all the different processes that were needed. We included various stakeholders from executives. For example, when we were really looking at diabetes and the pathways that we needed to develop, we included our endocrinologist throughout all the different phases of care, and in ways that clinical informatics could support these work groups moving forward. Our intended outcomes, we started out when we were looking at our perioperative, our pre-surgical services department, we really wanted to look at improving our patient experience, really having that patient-centered approach where it's like a one-stop shop that they can go in, They can have their comorbidities managed and identified, and also work on transitional care planning so that we can safely and effectively discharge them to home. In intraoperative, we looked at reducing clinical variation and overall cost. The days of physicians ordering whatever type of nerve block or fluids that they needed, we really had to come together as a group and determine what is evidence-based research that we can put in place here to overall standardize, be more efficient, and reduce cost. From postoperative, really looking at that right level of care. Are we effectively managing these patients from a pain management perspective, and looking at prevention of complications. Long-term recovery, we looked at coordinating a discharge care plan. We developed a role called the nurse care guide, who really followed those patients 90 days post-discharge, that she could effectively transition them to the appropriate level of care and work on maintaining their independence and preventing readmissions. Now I'm going to turn it over to Lindsay Satterfield to talk about the IT tools that have been utilized.
Hello, I am Lindsay Satterfield. I'm one of the IT application, lead application engineers. I've been with TriHealth for 5 years, and I've been on this project since the beginning. So for the next few minutes, I'd like to discuss the workflow and then the tools that we utilize to bring this program together. So beginning with the workflow, it starts in the office from the physician's decision to have the surgery. Then they put in the referral, which is done via Epic. From there, at the same time, the scheduler will then schedule the surgery, and the referral would go to the work queue for our nurse navigators, who are PSS nurses. From there, they begin to do a chart analysis of the patient and of the optimization. They then send the chart to our nurse practitioner, and she then begins the pathway, our clinical pathway, places the orders and any additional testing that may need to be done for that patient. At the same time, that patient would then come in for their surgical optimization visit, and they may, if appropriate, have an ostomy referral visit at the same time. The nurse navigator does an OSA assessment, a NSQIP assessment, other risk calculators to identify if that patient is at risk. The nurse practitioner will initiate any additional orders or initiate any additional assessments that may need to be completed prior to the patient going to surgery. On the day of surgery, the patient will arrive, and then the pre-op nurse begins her workflow. She completes the pathway steps for day of surgery, and then they complete the surgery. Once intra-op, if the patient goes to ICU, the pathway is discontinued. If no unnecessary upgrading care has occurred, they then go to the PACU, and the PACU nurse then begins her process. At the exact same time, the surgeon or the resident enters the post-op orders via the pathway. The patient then continues to the floor for the post-op day 1, post-op day 2, and post-op day 3 work that is completed by the nursing. During the discharge, they work with the discharge nurse navigator as well as the nursing staff to complete the discharge planning for the patient. There's a warm handoff given to our TSOC discharge care navigator, and she then reaches out to the patient within 72 hours, 30 days, and 90 days, as well as many other times throughout their participation in the program. She completes a patient engagement survey, reviews discharge instructions, med-rec review, assessments for ostomy if appropriate, any wounds, any additional diabetes assessments, and even checks with the patient to ensure they have the scheduled appointments for primary care and the surgeon post-discharge. Once the patient meets the 45 days, they send a letter letting them know where they are in the program, And then at 90 days, they send a congratulations letter to the patient letting them know that they've completed our TSOC program. So kind of going through the workflow, and I'd like to then show you what we use in this workflow to help make this program successful. To begin the inclusion to the program, it all starts with the referral. As seen on the screen, we have a referral order placed by the surgeon, and the order contains specific questions to drive the nurse navigator and the nurse practitioner workflows. It contains a link to reference documentation. And then finally, once the referral is signed, it triggers a silent BPA that automatically tags the patient in the program. The next step in the workflow seen on the bottom screenshot is our work queue. The nurse navigator performs chart analysis using the work queue. We've created specific columns for the work queue to help downstream information. And then it also comes from straight from the referral. To flag our patients, we have automatically patient flagging to help identify and track patients throughout their continuum of care. Based on the referral order, this is automatically adds an FYI to the patient's chart, and then it fire headers, as seen in the screenshots with the bright green banner. This is all done through a BPA. This has been added to navigator sections, status boards, master daily schedules, index reports for all clinicians, physicians, nursing, lab, care management, and additional clinicians, as well as other numerous decision support tools. Also continuing on with our best practice alerts, we've integrated several of BPAs, silent and end user facing. We've created a BPA for diabetes, checking which will automatically recommend a preoperative diabetes education referral, as well as assign and held post-op consult to the diabetic advisory team. Also, one opportunity we identified that was a good, One opportunity we identified was to simplify the communication between TSOC nurse navigators and the TSOC nurse practitioners. Is a solution. We created a BPA that would automatically send a in-basket message to the nurse practitioner in a specific TSOC in-basket folder that they would be able to use to then open up the encounter and place the orders using that in-basket message. Also, we use these questions from the surgeon's referral to build behind-the-scenes BPA records to automatically default an order to a specific answer. For instance, the surgeon marks yes to the patient needing an ostomy consult. This will then default the order in the pathway for the nurse practitioner. In our clinical workflow optimization, we built a specific navigator and sections that are restricted based if the patient has the FYI. In the navigator, we created several calculated flowsheet rows that help drive clinical decision-making. For example, disability, frailty, and nutrition assessments. We created quick hyperlinks that quickly link to websites such as NISQIP and our TriHealth internal intranet, where the outcomes are located. We've added a communication management section with a pre-made letter to specifically built for TSOC that contains lists of optimization pathways to send to the surgeon and PCP. We created several status board reports to help the nursing staff locate these patients easily. And to help break down the silos and bridge the related encounters, we took a pioneering approach and configured the pathway workflow to be initiated in the outpatient pre-surgical service encounter. Then we utilized the master daily schedule to transfer the pathway from the office encounter to the surgical hospital admission. We created new columns on the master daily schedule to help identify the patients that do not have an active pathway on the upcoming admission, as seen in the below screenshot with the green check mark. The bulk of our build was the clinical pathways. The pathway contains pre-op, surgical, and anesthesia orders. This reduces duplicate orders and ensures the patient gets all the necessary preoperative testing. In addition, it contains standardized patient education template, required flow sheet documentation, and TSOC-specific patient outcome goals. We built clinical outcomes and variances specific to the patient pathway goals. We built criteria records to suggest outcomes met or not met based on clinical documentation and results, which helps reduce double documentation. For example, if the patient was a smoker or a former smoker, it would suggest that outcome as not met or met. In the pathway review, it is an activity that is available for all clinicians. It contains a snapshot of all completed documentation within each phase of care. It uses stoplights to indicate if the patient has completed that phase of care, or if there is additional missing documentation, or if the patient has not met specific goals for that phase. It is indicated with a red or green color. It contains outcomes, flow sheet documentation, and orders. The users can then use the toolbar at the top to document outcomes and release orders. We built this specifically for TriHealth. In addition, it is one way for all clinicians to find all documentation in one centralized location. We've also created a special patient summary report used for troubleshooting. This helps administrators, educators identify if there are any missing steps or the pathway was discontinued erroneously. It gives a very high-level view. For physicians, we've created a few things for them. We introduced the clinical pathway, which has helped minimize the clicks and work from a physician perspective, not only for pre-op orders, but also for post-op orders as well. In the post-op med rec, the pathway automatically appears for the surgeons and residents. They no longer have to search for specific post-op order sets, as well as the orders are all standardized. As Julie mentioned before, we have a discharge care guide. We created specific documentation for this care guide. The screenshots shown here are from her workflow. She makes contacts with the patient at post-discharge day 2, 30 days, and 90 days. In addition, contacting them several times throughout the course of the program, we built her specific questionnaires into flow sheets, which were able to abstract that data to identify any clinical variances and determine the patient's satisfaction. TSOC dashboards, we created multiple dashboards. One in Epic, as seen above in the first screenshot, is an operational dashboard. The Epic dashboard contains registry-based real-time reports that end users can add ad hoc. All TSOC program end users have access to this dashboard. This gives them the capability to track patients throughout the whole surgical process, such as the discharge care guide runs these reports to identify the patients she needs to contact or follow up with. The screenshot as seen below, the analytic dashboard, is used for administrators, surgeons, and leadership. It provides more in-depth analytics for data over time. I'd like to turn it back over to Julie to discuss our quality outcomes.
Thank you, Lindsay. So looking at the value and the outcomes that we have been able to present here, with the patient satisfaction survey, we did have a response rate of 84%. The surveys that were completed, 218 out of the 260 were completed. We did demonstrate an increased overall patient satisfaction rate from 76% to 83%. Also looking at our canceled cases, we went from 9 to 0. Again, I want to reiterate that 100% of all of our colorectal patients followed the TSOC clinical pathway, meaning if the surgeon deemed that this patient was appropriate for colorectal surgery and they put the referral in, all patients went through all phases of care from the time of the need for surgery to 90 days post-discharge. Our length of stay, again, we were also compliant with all of our care pathways. We were able to demonstrate a decrease in our length of stay down to 4%, which was an overall 5.8 overall reduction in our average length of stay. Also, we demonstrated a 67% overall reduction in our surgical site infection. And this was all pulled from our clinical data warehouse and financial data warehouse team. The next slide just demonstrates overall, actually this goes a little bit in more detail as far as our volume cases, where our pre-pilot was about 248 patients, and we had a percent readmission rate of 14, and we were able to go to an 8.2%. So really looking at a cost saving just from reducing readmissions alone. This is our overall project outcomes, just at a high-level glance. Again, our length of stay went from 8.2 to 4.8 this year. Our surgical and site infection, we had 21 reported, down to 8. Delayed cases, 9 to 0. And our readmission rate, 14% to 8.2. And our patient experience survey jumped from 72.5% to 83, with an overall financial average cost for the patient went from $11,700 down to $10,586. So we did overall, in moving through these patients through the system and early identification of comorbidities and transitional care planning, we were able to demonstrate an overall cost savings for the patient. So for our soft and hard ROI for TSOC, we were able to demonstrate our readmission rate. We saved about $173,000. And that was really based on taking our average readmission rate of what it would, the average cost of what it would be coming into TriHealth, and applied it to how many readmission rates we decreased by. Same thing with our reduced surgical site cost infection. We took the average of what that would be and demonstrated an overall $14,000. And reduced cost per case, $287,820. And a cost avoidance for canceled cases was close to $67,000. We averaged, typically a minute late in your surgery case could average anywhere from $50 to $150. So we were able to use our efforts here to determine that overall estimated cost savings, with an overall ROI of $542,000. So we definitely have been able to demonstrate some success, but we also know that there's improvement in sustainability. So our keys to our success: we really want to look at our usability testing, really engaging our end users to use the usability testing during the pathway and workflow development. Really, we have information systems was a critical part of our care team, and they worked hands-on with our team members throughout all phases of care, working them through the pathways, working through barriers, overcoming anything that really delayed us in moving patients through the system. So they definitely played an instrumental part. TriHealth has a very strong culture of partnership between all of our team members. We value everybody. It really was a multidisciplinary team approach. It's a big patient care team, such as our PCP, our endocrinologist, our cardiologist, all played different parts in the pathway, really looking at evidence-based literature, what's really out there that would be that we all could standardize and know that this is the best research out there to provide the outcomes that we needed. For our lessons learned, staying focused on the why, I think that was always we are looking to market and communicate that to all team members, from those that are making the follow-up phone calls to patients, to the surgeons that are there in the office determining the need for surgery, why we are doing this and why it's the best thing for our patients. We did establish a steering group that provides oversight, alignment on all the work streams. We continue to meet on a regular basis. The level of process change can be very high and complex. We chose, again, a pilot area that we knew was small, manageable, that really had engaged physicians with the right focus on where we needed to go with this type of model of care. Really involving with all the work groups that we were able to demonstrate here in the presentation, really involving all the team members again, that they were all valued at all levels of care. Collaboration and teamwork, and really delivering a product that makes sense for our patients. Moving forward, as for TriHealth, we do plan to expand our surgical optimization center and our clinical pathways. We are currently working on adding additional service lines around ventral hernias, urogyne, and urology. We also are embarking on an enterprise system-wide project that based on the clinical pathways that our informatics team has been able to put in place, we really have been able to demonstrate a standardized approach to care with reduced clinical variation and better efficiency. And so we are looking at OB and spine to utilize these pathways from a system-wide at all of our health systems within TriHealth to utilize. We are currently looking at ways to increase our patient engagement through MyChart questionnaires. And we are also looking to pilot here this fall surgical text reminders to our caregivers and our family members throughout all phases of care, keeping them in touch with what's going on with their loved ones. As Lindsay mentioned, with our nurse care guide, she currently has workflows that she is working on when she follows up with her patient. We will be looking to mature those clinical pathways for our care guide nurse to follow from an outcomes documentation perspective. And we will continue to look for ways to refine and improve the efficiency of our workflows. I do want to provide some recognition that our TSOC has been recognized for. We have been recognized as the Industry Leader Innovator Award through our American Society Anesthesiologists. We also were nationally recognized at ASPEN, which is the Peri-Anesthesia Nursing Society. We won first place for national recognition. And we also, a Studer group, which is part of our consulting group that we work closely with here at TriHealth that is moving us in our clinical transformation. Our program has been recognized as what is right in healthcare nationally, and we will be presenting that here this fall. In wrap-up, I'm hopeful in this presentation we were able to identify the need and the why we need to continue to improve the way we are providing care by reducing clinical variation, improving efficiency, leveraging our core systems and clinical pathways to allow us to do that type of work, to overall provide the value of reducing length of stay, readmissions, surgical site inspections, et cetera. So I appreciate the time today that we were able to share with you. And I'll turn this over to Arnold.
Okay, thank you so much. Thank you all for that great presentation. I just want to remind folks where to go find more of these valuable and quality Davies use case recordings. That information can be found on the Davies website at hims.org/Davies. You can learn more, find more of these recordings and information on how to apply for the Davies Award. So once again, I just say thank you again for your recording.